Hi everybody and welcome back to I Am Journal Club. Our guest today is Dr. Christopher Cannon. He's a cardiologist at Brigham and Women's Hospital and a professor at Harvard Medical School. Ezetimibe or Zetia plus a moderate intensity statin versus a high intensity statin. That topic might appear a bit dull and maybe not so relevant, but maybe only at first. What might add to the confusion is the study design. It's a non-inferiority trial. However, and I will ask Dr. Cannon about this trial might be the answer to a very important question. What do we do with patients who are intolerant to higher doses of statin? Can a statin-sparing regimen be the answer? First, the nuts and bolts of the study. This was a randomized controlled trial of a high-intensity statin, rosuvastatin 20 mg daily, versus a moderate intensity statin, 10 mg of rosuvastatin daily, plus 10 mg of ezetimibe or Zetia. The trial recruited 3,780 patients with atherosclerotic cardiovascular disease and followed them for 3 years. The primary endpoint was the composite of cardiovascular death, major adverse cardiovascular events, or non-fatal stroke, and was reached in 9.9% in the high-intensity statin group versus 9.1% in the combination group. The non-inferiority analysis, with a safety margin of 2%, did not find a statistically significant difference. Let's jump right in. Dr. Cannon, thank you so much for joining us today.
Well, thanks so much for having me.
So you are a cardiologist who has run major trials of statins and other interventions to prevent major adverse cardiovascular and cerebrovascular events. What does it give you as a clinician and investigator to help patients, whether they're your own or whether they're more indirectly affected by your research, to prevent disease? Is that a very abstract thing to think about?
Well, I think this is why we're all in medicine, is to be able to help patients directly, and then in academic centers where we can try and pull together or do, research to find new approaches that then can help others, worldwide. It's been a wonderful time in cardiology, but in all of medicine now. Certainly in cancer has, got amazing advances. But in cardiology, there's just been in all different areas so many advances that we can now offer patients that it's quite different than when I was an intern of what we could offer. And so that's been wonderful to see of all of our collective work has really changed the treatment of patients dramatically. And of course, their outcomes are much better as well.
So talking about the racing trial, this was a study with a non-inferiority design, and to summarize, it proved that the additional LDL lowering effect of ezetimibe or Zetia in combination with a moderate intensity statin translates to a similar reduction of cardiovascular events in ASCVD patients compared to a high-intensity statin. You were the primary investigator and lead author for the Improve It investigators, and showed that adding ezetimibe to a moderate intensity statin can lower LDL and cardiovascular events further. What would you say racing adds?
Well, this is a wonderful study. And actually, back when we were designing the Improve It study, this was a design that we considered. And it was about half and half that people wanted to see, could we find a safer alternative to high-dose statin, where sometimes people can't tolerate the high-dose statin and need to have a lower dose, either myalgias or other, liver function test abnormalities or other side effects can happen. And so to have this study now showing that that's a perfectly good alternative, it's, slightly better even, but it has, a little bit more LDL lowering of adding ezetimibe. It adds about 25% LDL lowering, which is more than just a doubling of the statin dose. So it offers another strategy, really, an opportunity for patients to get effective lipid lowering if they've had any kind of issues with statins in the past. And of course, that's incredibly common for all of us, that, everyone's either read on the internet that the statins are the most evil thing ever invented, or they heard their next door neighbor had problems with statins, so they're not going near it, or they've had wondered if they've had issues as well. And so having an alternative to get people going and then have effective therapy is really wonderful.
You would agree this is a godsend for patients who cannot tolerate the high dose statin.
Well, I find, we certainly in ASCVD patients, we try to get people on high dose statin. And then if the LDL is not at goal, and so for them, less than 70 milligrams per deciliter is the US guideline. Sometimes if it's a recent MI, we'll push even less than 55. So that's more the add-on strategy that we tested in Improve It. But then the minute someone has problems with statins, if there are myalgias, then we quickly will then shift to trying to use a lower dose of a statin, which often is better tolerated. But then, of course, you lose LDL lowering, and so needing to add another agent. And so ezetimibe is a wonderful thing to then add. And now we have the evidence of this combination of moderate intensity statin and ezetimibe being equal to the high dose statin. So it provides nice evidence for this. I hope that it will remind people really that there are alternatives beyond statins.
And so the absolute difference between the two groups was 0.8%, and there was no statistically significant difference between the two groups using the predefined 2% non-inferiority margin. Going over the individual results and the secondary composite endpoint, as well as the subgroup analysis, there's nothing here that would jump out at you, is there?
No, I think, with a sort of a moderate size trial, the minute you start breaking down into individual endpoints, they don't have as much power and hence wider confidence limits. For the Improve It trial, adding ezetimibe, it's a modest LDL lowering, especially on top of, we started with an LDL of 70. So we were at the guideline that we had to do an 18,000 patient trial for 6 years of mean follow-up. With 5,000 events. This study had, a little under 400 events. So, the Improve It trial, to really be certain, was more than 10 times the size. So we were able to look at some of the other more individual components, but I think here one has to match the size of the trial to how much you slice and dice it and really just take away that this is a good strategy to be able to use with patients. The place that I find this comes up with patients the most is a very appropriate risk of statin therapy, of the risk of developing diabetes. And so this has been seen in several of the trials. There have been meta-analyses that there's a modest increase in the risk of developing diabetes with regular dose statin and a higher risk if it's high dose statin. So that's, as opposed to some of the crazy side effects that people see on the internet, that's a real one. And so many times patients are concerned about that and don't want to be on high dose statin. And so they say, okay, fine, let's use a low dose statin and add ezetimibe. And ezetimibe has no effect on development of diabetes. And, in this racing study, it was close to significantly lower risk of new onset diabetes of this sort of statin-sparing strategy versus the high-dose statin. So that's probably one of the most common things when I have a patient on moderate dose statin, their LDL is not quite at goal, to say, well, we could go up on the dose of the statin, or we could add ezetimibe. And there's a benefit of the adding ezetimibe approach that you'd avoid some risk. That's a higher risk in people with pre-diabetes. Obviously not relevant if they already do have diabetes, that's not an issue. But and so for healthy non-obese patients, it's a pretty low risk of developing diabetes. But nonetheless, I think we now have this alternate strategy.
Yeah, I think in this trial in racing, there was an 8.2% risk in the high intensity statin group for discontinuation or dose reduction versus 4.8% in the combination group. So 4.8% is not particularly high, and the risk is 42% lower in the combination group. So I guess that begs the question: should everybody be on a combination therapy?
Well, the part of the reason that we stick with statins first is probably the evidence base is so large that we've done trials for 30 or 40 years now. And proven mortality benefit is seen in different settings. And so I think it's very reasonable to start with the statins and, if tolerated, a higher dose. But I think now, if there are issues, it used to be that, oh, they can't tolerate a statin, that would be the end of the road, or, oh, we have to just use the lower dose, that's all they can tolerate. That now we move on to make sure that we reach the LDL goal with alternate approaches. There is a move afoot in cardiology to speak about earlier use of combination therapy. Typically, it's a step-by-step approach, and I have to say, I almost always do that, of a step-by-step. But the notion of, if someone came in, say, with an MI, and their baseline LDL was 175, that it's unlikely, even with high dose statin, they'll get to less than 70. That one could say, well, let's start with high dose statin and ezetimibe to make sure that they get to goal. So earlier use of combination does make sense. There are all the cost issues that sometimes, if you're taking 2 pills, it's 2 copays, and amazingly enough, insurance companies and different pharmacies charge crazy different prices. That CVS versus Walmart is often much higher price for some of the statins and for ezetimibe, and there's sort of cost barriers as well that sometimes get in the way of this and just about every other medicine we try and prescribe.
Yeah, I guess that would be another concern, lower adherence with more pills, especially if patients are already on treatment for hypertension or diabetes. But there's these fixed dose combinations available now for ezetimibe beyond simvastatin. I think there's a combination pill with rosuvastatin, and also in other parts of the world, maybe with atorvastatin. Have you had experience prescribing these? Have you had any issues with pharmacies or insurance plans?
Well, I certainly have. I usually do, get to them by adding the individual ones, in part to sort of make sure that if someone did have a side effect, we'd know which one new medication we just added that one could attribute it to. But it is available that then reduces the copay, reduces pill burden. So I think it certainly is an option. And they are used more widely, I'd say, in Europe. So it's definitely an option. The poly pill is a little bit of that concept, that they're having a lipid lowering, but also usually blood pressure and antiplatelet agent as well. The tricky part with that is dosing. That if you have to adjust the dose of one or the other agent, then you have to get a whole new pill. And then I don't understand the insurance and the pharmacy coverage that, on all these generic medications, depending on what plan and pharmacy you land in, there's wildly different prices. And so the same is true with the combination. They'll say, oh, it's not covered, or, just the formularies of the different insurance often are a barrier.
So if there's no fixed dose combination available, should patients who can tolerate high intensity statins, should we keep them on those and not yet switch them to a moderate dose statin plus Zetia, given there might be the same effect on cardiovascular events, and maybe there might be lower adherence with more pills, even if there is maybe a slightly lower risk of diabetes?
Well, I think, patients are tolerating things well, that I think sticking with that, high dose statin therapy has had, a multitude of trials, each showing benefit. But, if tracking the hemoglobin A1C can be a factor. So if you start to see it trending upward, that would be a reason to say, gee whiz, maybe let's go to a lower dose statin and ezetimibe, if they're at goal. So I don't think one needs to think about switching people who are doing well. But if there are issues with muscle aches or new onset diabetes, that certainly can be a good reason to, and we have evidence to say now that that's a good idea.
Hmm. Going back to the paper, if you look at the Kaplan-Meier curve for the primary endpoint, you already mentioned that there's a slight difference. Would you expect that maybe to increase over more than 3 years, maybe become statistically significant if you did a superiority design? Or if so, maybe the difference would probably only be tiny, wouldn't it?
Well, the difference of outcomes has been seen to be directly related in all the different trials to the amount of LDL difference between what you're treating. And so there was just a modest, I think it was about 8 milligrams per deciliter difference in LDL. And so, that's a modest difference. And so one wouldn't actually expect it to be that much better. So you'd have to have a gigantic trial, even bigger than Improve It. In Improve It, when we added ezetimibe to the same background statin, it was about a 17 milligram per deciliter difference. And that was starting at, 70. Other trials, when you add ezetimibe, it's a little bit more. If you start with, say, a background of 100, say, that absolute difference in LDL is what determines the relative benefit overall. So I don't know that, the benefits are generally proportional. Often takes about a year or so to start seeing benefit, but sometimes we see things sooner, but it's generally proportional over time. So I think that the finding is sort of exactly what you'd expect, just ever so slightly better with this ever so slightly lower LDL, and then, a bit better on the safety profile.
And on the other hand, as a trialist, would you have expected maybe a smaller difference if there had been a double-blind design?
Not necessarily. The endpoints here are big events, MI, stroke, hospitalization for, heart failure, PAD, and, so those are usually well documented, and there's not a big difference. In open label designs, it's sometimes a little tricky in strategy things, but this, I don't think that would have been a big factor.
Great. And then finally, in terms of the mechanism of action, ezetimibe is a selective inhibitor of cholesterol absorption. What about the anti-inflammatory and the pleiotropic effects of statins? Are they maybe less important than we used to think?
No, I think, there are anti-inflammatory effects with ezetimibe. You do see a reduction in CRP. So there's an anti-inflammatory component of it. I don't know the exact mechanism, but, it was proportional roughly to what about half of the difference of high dose versus regular dose statin, but nonetheless a significantly lower HSCRP was seen in Improve It, adding ezetimibe. So there is that component with this therapy. I should note that that's not seen with PCSK9 inhibitors, interestingly, that there's not a reduction in CRP, but there is with ezetimibe. So, we have seen, much of the benefit relates to LDL lowering. Some of it may relate to anti-inflammatory effects, and ultimately will tell best with the pure anti-inflammatory drug. So as initially tested in the CANTOS trial, there are other trials ongoing now with more potent anti-inflammatory agents to see, does that translate into benefit? And then we can try and tease out how much benefit with the statin was attributable just to the LDL versus to the anti-inflammatory component.
And then is there anything else that you want to convey to our listeners and viewers?
Well, I think my big takeaway in the last several years with this trial included is that we now have lots of options to treat cholesterol. And so it had been that, oh, we have problems with statins, and that was sort of the end of the road of the discussion. But now ezetimibe is next, but then we have PCSK9, bempedoic acid, colesevelam is well called, the brand name. So all those things are options that we can offer to patients. And so if there are issues with patients tolerating different things, often there are lipid clinics. I'm part of the group, at the Brigham that, receives lots of these patients to find regimens that work. But, in primary care now, realizing that, we have good evidence for ezetimibe, that can simply be added next as part of routine lipid management, with a good evidence base now. We didn't talk about, but there is a primary prevention trial with ezetimibe alone. It was called Utopia 75. So no statin background, adding ezetimibe in elderly primary prevention patients, and there was a significant benefit. So in the different ways to use it, we have trials showing benefits. So it can sort of make its way into routine care, I'd say, in primary care as another thing to offer to patients to get their LDL down.
Dr. Cannon, thank you so much for this conversation.
Well, thank you very much for having me.
Here are my 4 personal takeaways from our conversation with Dr. Cannon. First, 10 milligrams of rosuvastatin plus 10 milligrams of ezetimibe is as effective as 20 milligrams of rosuvastatin in preventing MACE in ASCVD patients. Second, ezetimibe is an add-on option when the statin dose has to be lowered, for example in patients with statin-related side effects or at risk for diabetes, for example pre-diabetic patients. Third, lowering LDL is proportional to reducing the MACE risk. And fourth, ezetimibe is anti-inflammatory. Thank you for listening to or watching this episode of I Am Journal Club. If you liked this episode, please subscribe to our YouTube channel or our podcast and recommend us to a friend or colleague. See you in the next episode.